Thumbs up, Steph, if they are. Beautiful. Excellent. Right then, so audience participation, which doesn't really work when everyone's on mute. You may not know the significance of this gentleman to Lupus. You may not be familiar with him. He was one of the characters in House, the series, and one of the themes of the series House was that it was never Lupus. It was a standing joke that somebody would suggest Lupus and somebody would say it's never Lupus, to the point that he actually had his drugs stored in a Lupus textbook up until the point this guy came in. I believe it was about series five. And at that point, it actually was Lupus. So I think they probably threw that in there because they were probably getting concerned letters from people with lupus who were worried that they people would think that House MD was a documentary. Sometimes it is lupus. Why lupus? It's an odd name for a disease. Obviously, lupus refers to lupine, the Latin word for wolf. Um, and I didn't know this. It was attributed to a 13th century physician called Rogerius, who used it to describe the erosive facial lesions that were reminiscent of a wolf bite. He thought that the lesions looked like you'd been bitten by a wolf. This is the closest we have to a photograph of Rogerius. Um, and my first thought there was that they really, really don't. How does anything look like a wolf bite? And then I Googled what does a wolf bite look like, and it actually really, really does. You've got those two half circles, you've got the sort of punched out sections of it. That's pretty uncanny. Um, I suppose I should really have had more respect for somebody in the 13th century's ability to spot a wolf bite because they would have seen a lot more wolf bites than me. Um, Also, just as an aside, and I do love woodcuts, I don't know what exactly the progression is in this woodcut. But if you look at his face in the first picture, he looks quite chuffed, and by the end, he really doesn't. I think we can all relate to treatments like that, where it starts going well, and by the end, the damn toenail won't come out, or the lesion won't stop bleeding, or whatever. So yes, poor old Rogerius called it lupus quite correctly because it actually does resemble a wolf bite. So we're going to talk about three things this evening. We're going to talk about lupus, what it is, in the interests of Lupus Awareness Month. We're going to talk a little bit about the mechanisms, the symptoms, and how it presents. Because this is for podiatrists and FHPs, we're going to talk specifically about how lupus affects one's feet. And then we're going to go into a little bit of detail about how we can actually help our patients who have lupus specifically, what we can do to contribute to their care. So, what is lupus, first of all? Lupus is an autoimmune disease. It comes under the category of rheumatology. And like most autoimmune diseases, it is to do with your bodies. Your body makes antibodies to fight disease. So usually they're a good thing. But if you overdo it, if you boost your immune system, it is a very bad thing to do. So all those people that try and sell you stuff to boost your immune system, it's fortunate that they don't know what you're talking about because you can't just dial it up like a thermostat and make it stronger. An autoimmune disease is a boosted immune system, and it's something you do not want. So here's our antibodies doing their job, being policemen to our bodies. They walk around our bodies, looking after our cells and keeping an eye out for anything which might harm us, any pathogens, any viruses, bacteria, things which should not be there. And generally speaking, that's exactly what they do. And like the good men and women of the police force, the vast majority of them are very competent and very sensible and do everything exactly right. However, sometimes they can get a little over enthusiastic. Sometimes they can get a little stick happy. Um, I never miss an opportunity to put this. You don't know if you can see that guy's thing on the back of his flat jacket says police medic. And he's thumping people enthusiastically with his wellness stick. I think that's beautiful. But More generally, there are lots of examples of where police and or militias, which purport to be there to look after us, actually start working against us. This is obviously Tiananmen Square in China, and this is one of the American militias who struggle their way into combat gear to protect freedom in America, provided that doesn't involve climbing any stairs. They're the Gravy SEALs. So, in an immune system, and in lupus in particular, in short, the body decides to attack itself. Um, the body should be able to identify harmful pathogens and eliminate them, and identify joints and look after them. But if you have lupus, your body doesn't know the difference between these two things. It will indiscriminately attack both. Um, There's another rather nice meme here. This one is partially accurate. Um, I don't know if you've seen it before, but the idea is that this chap with a rocket launcher who is threatening this hostage is not likely to be very popular among his comrades because if he pulls the trigger, everything's going wrong. And that is very much what happens with lupus. The immune system um, is so enthusiastic about destroying the things that it doesn't like, that in the process of it, it ends up blowing up an awful lot of stuff that it does, or that it should. Autoimmune diseases are badass in the sense that the only thing that is strong enough to mess you up is yourself. You'll get increased antibody levels. So, in general, your antibody levels will increase. So, there are more policemen running around than are needed to do what needs to be done because the immune system is boosted. But also, we have a very specific type of antibodies, which are not so much found other ways. They're called anti-nuclear antibodies. That is the nucleus of your cell, not any other kind. Um, and they are antibodies which specifically target and assault the contents of the nucleus, or the nuclei, I'm sorry, of your cells. And if you know anything at all about cells, you know that the nucleus is where all the good stuff is. That is where your ATP is, your DNA is, your RNA is. Um, you don't want that being attacked. So these are the bad cops. These are the antibodies which have not only lost the ability to distinguish, but actively now are targeting the good bits of your cells. And these ANAs, these anti-nuclear antibodies, are ubiquitous in lupus. They are present in almost everybody who is positive for lupus. However, they are also detectable in 20 to 30% of people who don't have lupus, which is an interesting statistic, I thought. So even if you don't have full-blown lupus, some of your antibodies are turned inwards. There are still some bad antibodies. There are still some antibodies which are attacking you, even if you don't have a full-on autoimmune disease. Another interesting statistic in the same context of that, and all of these, by the way, the references are all on the slides, is that 3 to 5% of the population have some form of autoimmune disease, and that's diagnosed. So of that 20 to 30%, it's entirely possible that 5% or 3 to 5% have got them because of some other autoimmune disease. These things are not unique to lupus. Um, but it's going to be a continuum. It's not going to be a binary. There's going to be people with higher levels of ANAs who have got a more active disease, and people with a lower level of ANAs who will have a less active disease. Um, which is not to say there's such a thing as mild lupus in the same way as there's no such thing as mild diabetes or mild Parkinson's. But it does mean that at different times the disease can be more or less active. So in terms of the symptoms, um, there was a fairly broad scoping study here, and this is looking at symptoms throughout the whole body. These are all symptoms of the body attacking itself. These are all the outcomes of your ANAs, your antibodies assaulting your own tissues. They offered 38 different symptoms to choose from, which is a standard questionnaire for broad disease. And people came back and they reported which of these symptoms they suffered from. People who had lupus were screened. They were also asked how bad the symptoms were on a 4-point scale. So one being no problem, not burdensome, to four being very troublesome. The average lupus sufferer came back with 12.9, so nearly 13 different symptoms. That is a prodigious number of symptoms. A lot of very different things can go wrong when you have lupus. And that's the average. So some of those people had even more. There was a fairly broad spread as well in the severity of symptoms. So spontaneous bruising, for example, only 1.9 on the severity scale. So although quite a lot of people had it, almost over half of the respondents had it, they weren't reporting it as particularly severe. Bearing in mind the scale goes from 1 to 4, so there is no less than 1. Whereas fatigue is the most common symptom, 2.7, so very much more severe as well as being more frequent. The other thing that the authors commented on in this study was how heterogeneous the presentation was. So heterogeneous just means different. Everybody that gets this disease gets a different spread of symptoms. There are the very popular ones that more or less everybody gets, but there's an awful lot of difference in the other ones. There's a lot of difference in terms of the severity. And that makes it potentially hard to diagnose. It makes it potentially quite difficult to come up with treatment algorithms and treatment pathways because two people with lupus might come up with non-overlapping symptom sets. They might have completely different experiences of the same disease, which is not something you tend to get in things like Parkinson's, things like diabetes. There tends to be everybody gets more or less the same. So just to run through them quickly, joint muscles, aches and pains. That is one of the more common ones. Extreme fatigue and weakness, increased risk of miscarriage in women of the correct age. Rashes, very common. We're going to look at some of those in a bit more detail, including the classic butterfly rash. Flu-like symptoms, you can get a fever because, of course, your immune system, when it really thinks that you're in trouble, dials up the thermostat and makes you hotter. So you can get a fever, you can get night sweats, weight gain, weight loss, inflammation of the tissues covering internal organs, which causes chest and or abdominal pain, seizures, mental illness, other cerebral problems. It can attack neurological tissue, headaches, migraines, kidney problems, mouth ulcers. That was a new one on me. I didn't know that that was one of the things. Hair loss, depression, hematological disorders, including anemia, swollen glands, and problems with circulation. Now, this list comes from Lupus UK, which we will talk about a little bit further on. It's a very complete list. I was quite surprised at the order that they put them in, because based on some of the statistics, I would have thought that some of those would be further up the list. But the conclusion, there are many possible manifestations of lupus. Those are the common sequelae, but there are others. Lupus is a disease that can present with many different facets, and very rarely do two people have exactly the same symptoms. They can vary from just having one symptom to having lots. Makes it hard to diagnose. Everybody with lupus is an individual. They all require individual management. So just to hit a few of the high points, we're not going to go over that entire list. But just to hit some of the high points. Lupus does present with a classic rash, the butterfly rash, down either side of the face, which is why the symbol for Lupus UK is a butterfly. Um, Sometimes it can be quite sort of mild, sometimes it can be much more severe. And one of the reasons that it presents in that shape is that that is pretty much where you're going to get sunburned. And people with lupus are very often triggered by sunlight. So a lot of the locations that you will see the lupus rash are locations which are exposed to sunshine. Not all of them, but certainly some of them are. Um, which means that one of the things that you do need if you suffer with lupus is you have to be wearing factor bus shelter sunscreen, sunblock. Because even a small amount of sun exposure will have a disproportionate effect. Kind of sucks because being out in the sun is nice. Another big one that triggers lupus is stress. Um, Psychological stress. They mention a few examples. Bereavement. Bereavement is a fairly good one to study because it is objective. It is something that you can actually ask somebody after you had the bereavement, did your lupus flare? Redundancy, divorce. The thing that has been spiking my stress level today was a thread on a forum where somebody was saying, in all seriousness, that ingrowing toenails are caused by an imbalance of energy in your liver, which apparently is centrifugal. Okay. Um, but anything that triggers that kind of psychological stress or physical stress, if you have an injury, if you have a fracture, if you have a trauma, that can trigger it. Having surgery can trigger it. A systemic illness, particularly an infection, because of course, when you have an infection, what happens? Your body dials up your immune system. It produces more antibodies. And if your immune system is already a little bit twitchy, then there is every chance that that can cause a problem. Or just plain overdoing it. Um, a lot of people report with lupus that they have to husband their energy levels very carefully. Why is it husbanding your energy levels and not wifing your energy levels? It doesn't matter. That's completely irrelevant. Um, but you have to be a little bit careful because the problems that you will get when you overdo it don't necessarily happen when you overdo it. They happen the next day. So you have to be careful to manage it because lupus flares. Lupus is not a nice steady state. It undulates. It spikes and it drops back. A lupus flare is defined as when your lupus symptoms worsen and you feel ill as a result. Formal definition is a measurable increase in disease activity in one or more organ systems involving a new or worse clinical signs and symptoms and/or lab measurements. The increase must be considered clinically significant by the assessor and in most cases should prompt the consideration of a change or increase in treatment. That's I couldn't find anything on the Lupus UK website that defined flares, so which is why I went to the American one. That seems a very physician-centric way of looking at it to me. It sort of leans very heavily on the physician or researcher has to tell you you've had a flare. It has to be in their opinion that they've had a flare. I would like to see a bit more emphasis on the patient's experience, validating their experience. I'm inclined to believe them if they tell me that they're ill. Maybe it's different in America. Um, And it says also quite correctly, lupus is a chronic autoimmune disorder characterized by unpredictable degrees, disease flares and remissions. So sometimes you can do something about them. Sometimes you can manage your energy levels, you can manage your stress, you can manage your sun exposure, but sometimes it will just do its own thing. So that's lupus in general. Hello, sir. Um, that brings us neatly on to our bit, lupus and your feet. So I've taken these statistics from the most recent and the best study I could find on it, which was Simon Otter and et al. Which is a nice local author. Always support local authors. Um, and in his study, 77% of patients reported foot pain, a solid minority. If you have lupus and your feet are not hurting, you are a rare bird. Um, so it is very much tied in with podiatry and what we do. He divided where within the feet you get this pain, and it's pretty evenly distributed. Most of it in the ankle, 32% of respondents in the ankle, 30% in the hind foot, 29% in the midfoot, 28% in the forefoot, 23% in the toes. So, although it is more prevalent in the rear foot and becomes less prevalent as it goes forward, it's not by very much. It's only 9% difference between those two. Um, the sharp of eye and keen of mind will have noticed that those percentages add up to more than 100%. That, of course, is because you are allowed to have pain in more than one place. So it's entirely possible that, well, it's certain that a lot of those respondents will have pain in more than one location. But the study was silent on of necessity, on what caused the foot pain. This was just a study to look at did things hurt, didn't specify why. The ankle obviously is a joint, whereas the hindfoot is an area of the foot. Um, and this is seems to be the thing with lupus foot pain. It can be caused by more than one type of symptom. You can get soft tissue pain, you can also get joint pain, you can also get tendon or muscle pain. And the reason for that is that we are dealing with an inflammatory condition, not unlike rheumatoid arthritis, which in the same way will trigger lots of different pain in lots of different places and lots of different tissues. It's not a tissue specific condition. It will attack lots of different things. An interesting note that the study made, an interesting observation, is that with rheumatoid arthritis, we tend to see more forefoot problems, don't we? In rheumatoid arthritis, the toes and the MPJs, the small joints, are very, very specifically targeted, which is not to say that people with rheumatoid arthritis don't have rear foot pain, but it's much less common than having digital problems. Whereas lupus has a slight preference for the bigger joints, the tissues further back in the ankle and the tissues in the midfoot, for reasons that I do not understand. So, inflammatory pain. Um, we need to talk a little bit about inflammation because so far we've been talking about antibodies and the body's attacking your tissues. We've not talked about inflammation. Inflammation is defined as your body's response to an injury or illness or to the perception of an injury or illness. And that last little bit of that sentence is super important. Um, your body is very good at fixing itself. Um, when you get an injury, um, let's say you cut yourself. Um, we are the descendants of the people who survived cutting themselves. So the mechanisms that we have for dealing with it have evolved to help us. When you cut yourself, you get inflammatory cytokines. The body releases chemicals which sound the alarm. There is a noisy neighbor. There is a problem here. We're not sure exactly what it is. It's a fairly indiscriminate thing. You will get a similar cytokine reaction if you get a small infection or a small laceration or an impact or pressure or a chemical irritant. Lots of different things can trigger the inflammatory mechanism. But the inflammatory mechanism is how we get stuff done. It's how we fix things. Um, It means you will get redness. The redness is because you've got more blood to the area, because blood carries all of the useful things that we need. Blood carries your oxygen, it carries your nutrients, and of course, it carries your antibodies, your white blood cells. So if you have an injury, any one of those services might be needed. So you just get a general increase in everything. You get an increase in heat, which is partly a consequence of the blood vessels opening up, and connected to the way your body likes to deal with infection. You will get swelling, which will sort of splint and partially immobilize the tissue, and you'll get pain. Inflammatory pain gets a very bad reputation because usually in the contexts that we're looking at it, inflammatory pain is a bad thing. Usually we are talking about it in the context of a disease like lupus. But pain is your body's way of saying, right, that bit of you is damaged. Stop using it for a bit. It makes it unpleasant to expose that tissue to more load. It encourages you to not put that foot on the floor, not to rub that spot, not to scratch that scab. Um, it's not an accident that inflammation hurts. It is an evolutionarily advantageous trait. Um, and the loss of function is there in part to allow those tissues to heal. So usually inflammation is a very, very good thing. One of the one of the things that we have learned in biomechanics over fairly recent years is that although anti-inflammatories, whether they're steroidal or non-steroidal, ibuprofen, for example, although they will fairly reliably reduce pain in musculoskeletal injury, they will also delay healing. Because what you are doing is your body wants to send all this extra material to help you to heal, and also to make it hurt to stop you actually using it for a bit. You break that with the NSAIDs. You limit that response, which means that the tissues can't heal in the same way. Um, so one of the parts of the acronym we now use, we used to use RICE, rest, ice, compression, elevation. The one we use now is peace and love, um, which is protection, education, avoid anti-inflammatories. I won't go through the rest because that's a different talk. But it's actually specific now that as far as you can, you want to avoid damping down the immune system. So inflammation is usually a good thing, a good mechanism. But if you've got lupus, you're not getting a good, healthy, proportionate inflammatory response. You are getting an overblown inflammatory response, which is going to target and damage self tissues, these anti-nuclear antibodies. So when your body is trying to call for a little bit of help, a little bit of support to heal, what turns up is a very exaggerated response. This is pathological inflammation. This is the flavor of inflammation that we want to control, because this is inflammation which is not doing us any good. The body thinks that it's attacking pathogens. It is in fact attacking its own tissues. So the repair mechanism, this inflammatory mechanism that we all have that should help, actually becomes the problem. The pathology triggers more inflammation, a heightened inflammatory response. The inflammation triggers more damage to the tissue. The damage to the tissue triggers more inflammation. The inflammation causes more damage to the tissue. It becomes a vicious cycle. Um, and in lupus, we find that minor triggers can cause an exaggerated inflammatory response. The exaggerated response causes more tissue damage. The tissue damage causes more inflammation. Um, I don't know if anyone has seen this series of photos. It was taken in a harbour. It's a lovely analogy for inflammatory reactions in lupus. So a car has obviously gone over into the harbour, and a crane is sent to dig it out. So let's say the car represents the initial tissue damage, the crane represents the inflammation trying to help it. The crane falls into the harbour. So now, where we originally had a fairly small problem, we've now got a bigger problem because the inflammatory response itself has started causing the problem. So, what do we need to dig this exaggerated inflammatory response out? Well, there's even more trauma there, so we're going to have an even bigger crane. We're going to have an even bigger inflammatory response to try and deal with the damage caused by the initial inflammatory response. And lo and behold, that falls in the harbour as well. And what we end up with is an ever increasing series of inflammatory responses to the original insult to the tissue, which is actually quite small. So we are now dealing with our own systems, which have gone there to try and help and have actually caused more harm. So apart from foot pain, what else do we get in lupus? Well, again, like the general symptoms, there's a tremendous heterogeny, a tremendous variety in what people come out with. Um, this is from that same study. Um, the number one, in terms of if you add the number of people who sometimes get it to the number of people who always get it, is cold feet, which I would not have expected. The number two is swelling. Number three is numbness. Now, the numbness deserved a special mention in the discussion. This is self-reported foot complaints, so we shouldn't take this as being something which is a diagnosed pathology. This is the patient's interpretation of what it is, which is in some ways more useful because their experience is the bit that matters, not our idea of what it is. But it also throws up the potential for errors because sometimes people use words which are different, have different meanings to them to what they mean to us. Um, they specified it remains unclear if the numbness which was commonly reported is neuropathy, or if it's vascular, or if it's something different. We're not sure. We know that lupus can affect nerves, but we don't know if everybody that's reporting numbness has got that or if it's something different. Then we're into Raynaud's intermittent claudication. That's another interesting one. Um, and these are the vascular things. Foot complaints likely to be caused by impaired vasculature were commonly reported. So foot pain is your number one. That's the single biggest um, symptom that most people report. But vascular problems come in pretty tight behind. So it is very likely we're going to have both. Intermittent claudication is an interesting observation there. We'll come back to that. So just to recap on Raynaud's, which of course you can get as a primary or a secondary condition. Some people just have Raynaud's. Raynaud's caused by Raynaud's. Some people have Raynaud's as a secondary condition. Um, there are some lovely pictures of people who have it in their fingers, and it is really very noticeable in their fingers, where it's usually just one or one and a half or two fingers, which are bone white, or blue, because the blood can cyanose. In the feet, however, it's not just restricted to digits. These are interesting pictures because they're patchy. There's individual blotches on the plantar metatarsal area, on the heel there, on the apices of the toes. Seems to have a predilection for weight-bearing surfaces, which is not surprising because weight-bearing surfaces are under more pressure, which means the blood is being squeezed out of them more often. Um, but it's worth noting that it doesn't just affect digits, it can affect big surfaces as well. And it's defined as blood vessels constricting and restricting the blood flow to a particular area of skin. and it is connected with cold feet. If you have Raynaud's, you will be icy cold when the blood is not going into the skin like that. Um, but you have people who just have naturally cold feet, which doesn't rise to the level of Raynaud's, but is definitely in the same microvascular type of symptom cluster, if you like. And that was one of the very, very common findings, cold feet. Um, in the same rough ballpark, we have chilblains, or otherwise known as perno or perniosis. Perno sounds like a drink. Um, Chilblains are a form of localized vasculitis, so an inflammatory disease. We familiar with other types of inflammatory blood vessel problems, phlebitis, for example. Um, it's a very localized inflammatory reaction within the blood vessels. So again, we've got our inflammatory problems. We've got our antibodies, which are sparking off unnecessary responses to perceived threat or injury, not real injury, and then creating a threat and injury by their own response. Um, and it can be connected to Raynaud's in a number of ways. Chilblains are largely to do with the way that the blood vessels open and close, the speed with which temperature changes. And one of the things that you find with Raynaud's is that it can change very quickly. So it's entirely possible that the rapid changes in skin vasculature that you get with Raynaud's could be connected to or directly trigger chilblains. So it could be that these are a sort of parallel manifestation, or it could be that they are secondary too. Now the claudication, this was one that surprised me a little bit. Um, Claudication is where your calf runs out of oxygen. Um, the Fontaine classification is a lovely, simple classification system. Stage one, no symptoms. No problem. Stage two, it hurts when you walk a certain distance. Stage three, it hurts even if you just elevate the leg, so night pain. Stage four, things start going black and dropping off. Now, I found a few references that talked about claudication in lupus, but they were all talking about it as a quite a rare sequelae. They were case series with 10, 12 people, and yet the classification that we saw in the study showed intermittent claudication in sort of 42% of people, which is huge. It's a very, very large proportion. I would question there whether self-reporting is the right thing to do with intermittent claudication, because I don't believe that most people said, I suffer with intermittent claudication. I suspect what they said they suffered from was calf pain, and self-diagnosed it as that. But anyway, people with SLE, lupus, may well develop premature atherosclerosis, narrowing of the arteries, and we're not entirely sure why. Um, they did note in the study down here, which was a pretty good one, that there were specific risk factors within lupus patients for picking up claudication. 8 of the 10 people who had it had coexistent coronary artery disease or TIAs. So it's quite possible that it's caused by comorbidities, steroid usage, hypertension. A lot of the symptoms and secondary effects of lupus can separately predispose you to getting claudication. So it might be one step removed. I don't know. But it's there. Which brings us on to how we can help. Um, this photo, by the way, I absolutely love. Using AI to generate pictures is a lot of fun because sometimes they come out with some very odd things. I really don't know what's going on there. Um, the first thing we can do usefully as FHPs and or podiatrists is know about lupus. We can also help to manage their specific foot problems, the secondary sequelae, and we can signpost to useful agencies. In terms of knowing about lupus, congratulations if you are watching this video, you are doing that. Um, as Shakespeare said, um, be he ne'er so vile, this day shall gentle his condition. We have improved our knowledge, hopefully, today, which is useful. It's a quote from a sufferer. I'm not angry with my diagnosis, it's the hand I've been dealt, but I am bitter at the length of time it took me to be taken seriously. Where it is such a heterogeneous condition, such a varied condition in terms of its presentation, um, it can take a long time for people to actually take notice of it, which can be quite an isolating experience. Rare conditions are hard for patients. You get diabetes, they rush at you with Desmond and with education, and there's the charities, and everyone knows about it. And it's, you'll have lots of people at the bowls club who have it as well. You get diagnosed with lupus, you're probably going to be the only person you know who's got it. Um, so the fact that we know a little bit about it, um, will help your patient. The mere fact that when they say when they give their history, they've got lupus. Oh, yes, we know a little bit about that. Tell me about what's that like for you. Um, that in itself helps. Um, the defining characteristic of people with chronic pain is not that they're faking being sick, it's that they're usually faking being well. Um, some mildly alarming statistics here. 87% of lupus patients downplayed the symptoms in order to not upset family members. 52% minimized their symptoms to doctors. That surprised me. All found that it was difficult to describe the symptoms because some of the symptoms are woolly. How do you describe fatigue? If you're a sort of a parent of teenagers or toddlers or something like that, you've got a stressful job. How do you get taken seriously when you tell your doctor, no, it's not just I'm staying up late. It's not just that I need to have a jog. I'm not well. And 72% of doctors said they weren't aware of how severe symptoms were. So just the act of being aware about it, knowing what it is, which everyone who's got to this stage now does, being aware that the symptoms are so varied, being aware of what some of those symptoms are, just being able to listen intelligently about their experience so that they've got someone that they can talk to openly and not be greeted by a blank stare. That's something tangible that we can do. Um, with sensitivity. Because the other thing that I've heard from quite a few people with chronic pain conditions and indeed other chronic conditions, mental health conditions being the biggie, um, is that if you tell a certain type of person about it, they're all experts and you're going to get an awful lot of very, very shonky advice, which minimizes your condition and your struggle, from people who don't know enough about it. So by learning about lupus, we can not be those people. In terms of the specific foot problems, again, a lovely AI image there. There's an obvious anatomical issue there, which I'll let you figure out for yourself. Dorsal venous arch doesn't look anything like that. I don't know what they were thinking. There's quite a bit we can do. We're going to have to talk a little bit about biomechanics. I know that is not everybody's favorite place to be. There is no such thing as a typical biomechanical presentation for a lupus foot. There is for Charcot-Marie-Tooth. There is for Charcot. There kind of is for diabetes. Um, the biomechanics in a patient with lupus is as varied as the patients. So I can't give you I've got a talk called The Biomechanics of the Diabetic Foot. I'm never going to be able to write a talk, Biomechanics of the Lupus Foot. But in general, what we can do is try to reduce load on tissues. Load does not mean weight. Um, It's a term that we use in biomechanics. Load can be tensile, it can be things stretching, it can be compressive, it can be things squeezing, it can be different types of forces. It's a product of the amount of time you are on your feet, what you are doing when you are on your feet. You could weigh 8 stone and go for a run and have very, very high load. So we have to signpost that, because sometimes when you say talk to patients about load, the first thing they say is, yes, I know I need to lose weight. And we have to say, no, back up. Weight is a part of load, but it's a very small part of load. In general, what we want to do with people with inflammatory conditions is reduce load. And to grossly, 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 grossly oversimplify it, things which load feet in ways that cause discomfort. Impact is one. Hard surfaces, for example, wearing shoes which do not have cushioning, nothing to absorb it. And what we might call radical joint excursions. That does not mean taking a spliff snowboarding. What that means is your joints, when you walk normally, will work within a certain range. Those are the normal excursions of the joint. They're not static, they don't stay still. The graph that has the normal arched foot, which doesn't move when you walk, and the rear foot is nice and vertical, that's nonsense. The rear foot is designed to pronate and supinate. The arch is designed to flatten and recover. But those joint excursions usually will be all about the same. If you plot them on a graph, some of the joint excursions will be bigger. You will suddenly move further, and it's those big excursions of joints that tend to cause the problems, tend to cause the injuries and the load. And the end range of joints is the other big one. Happy, healthy joints generally work within their range of movement. The end range, where the joint can't go any further, like a door where you can't actually close it any further, that's where tissues start getting distressed. If we wanted to be super technical about it, we would say it was high residual moments in the subtalar joint tend to cause problems because they tend to be compressive within the sinus tarsi. If we don't, we just want to say you don't want the joint operating at full pronation or full supination. You want it operating roughly in the middle. So that is one slide's worth of biomechanics. We do not want to be slamming the doors. We do not want to be having the joints pushed as far as the joints can go. We want them to be supported, broadly speaking, within their preferred range of movement. So in terms of orthoses, I could only find one randomized controlled trial using custom-made functional foot orthoses for lupus patients. And the conclusion that they reached was that both the treatment group, who had orthotics, and the control group, who just had a cushion, showed improvement. Now, that's one of those things you could look at a few different ways. You could say that the custom insoles were no better than a simple cushion. That would be a true thing. The way they've chosen to say it is that this is brilliant. Both of them are equally good. It's probably not the result that they were wanting, I suspect. But a word of caution on that, and I am all about the evidence, but we have got to be careful not to over extrapolate the evidence. The experimental group received custom-made foot orthoses that were polypropylene, 3mm polypropylene shells, covered in 5mm polythene foam. So everybody in the custom group got the same type of insole. I would question whether that constitutes custom or not. Also, 5mm is hella thick. So if you're casting a polypropylene shell to the shape of the foot and then sticking a 5mm cushion on the top of it, you're losing an awful lot of the fine detail, and you will not be able to put a decent heel cup on it. Because if you think if the heel cup was nice and deep and you had 5mm there and 5mm there, you've made that heel cup 10mm narrower than the heel actually is. They won't be able to put their foot in it. So what that tells us is that we're actually looking at devices that don't have particularly strong heel cut. So if we're going to take anything away from this, it would be, first of all, just simply putting cushioning in the shoe. The 3 mm blank boron type cushion in the shoe helped significantly, statistically significantly. So just simple cushioning can help. Their suggestion is that custom insoles work about the same. I wouldn't over rely on that. And I would also draw your attention to what they drew your attention to, is that there are lots and lots of studies describing custom foot orthoses to treat problems caused by rheumatoid arthritis, which is similar in as far as it is an inflammatory joint condition. So certainly orthoses have a potential to help, but just cushioning has the potential to help as well. Speaking of cushioning, in terms of footwear, there are certain types of footwear which are designed very specifically to manage load, to manage those radical excursions, to absorb shock, to absorb impact. And they are by and large running shoes, because runners need to do all of those things. So running shoes, to a lesser degree, hiking shoes, hiking boots, things which are designed to manage load more generally will probably help your patients, but be guided by them in the selection of them. I don't believe that anybody understands human biomechanics well enough to be definitive about what is the best type of insole. There is so much variation within biomechanics, within the psychology of it, the physiology of it. But the person that does know is your patient. They know the difference between a shoe that hurts and a shoe that helps. So if they come back and say these shoes help, and you think, oh, that seems a bit dodgement, that doesn't seem right, I would very much advise that you believe them.
I can grab it.
They generally do know what they're talking about. As far as Raynaulds is concerned, the NHS has lots of advice on how to manage it. Keep your home warm if you can. Thank you, Mr. Starmer. That's going to be a little tricky now. Wear warm clothes during cold weather, especially on the hands and feet. I really like these little toe socks for patients, not for myself particularly, but I've had lots of people wear those and tell me they've done well. Avoid sudden changes in temperature, so hot water bottles, radiators, toasting your toes, going from cold to hot is a problem. Getting out of a nice warm bed and then walking around on a cold, hard floor, that can be a problem. Exercise to improve circulation is good. That doesn't mean going for a jog. That can just mean doing the alphabet with your feet while you're watching the final chase. This one seemed a little bit wafty to me. Try breathing exercises or yoga to help you relax until you realize that Raynaud's actually is triggered by stress. It can be triggered by stressful situations. So yeah, that's not a bad idea. So managing the triggers for Raynaud's, helping the. I'm just going to try and mute Liz there. We've got a bit of bleed over coming over on the audio.
Hello, Bob.
There we go. And advice on how to deal with an attack. So when you're having a Raynaud's attack, what do you do? According to the National Institute for Arthritis, Musculoskeletal and Skin Diseases, placing your hands or feet in a warm place, not hot, warm, so body temperature, or by sticking your hands in your armpits. You don't want to send the temperature higher than you want it to be. You just want to slowly bring it up to what you want it to be. And as far as chilblains are concerned, we can help with that. Again, prevention is better than cure, so managing the triggers, rapid temperature changes, much as with Raynaud's, smoking is the elephant in the room with chilblains. We might be able to support them there. There are medications which can trigger chilblains. There are also medications that can help chilblains. I'm not going to go into them in detail, but it's worth having that conversation. And the environment, controlling the environment. The shoes are the linings thick enough to give some thermal insulation? If not, can we put some in? Are the socks nice and thick, and do they wick well? Um, is there any leakage anywhere? Because if anything is even slightly damp, the thermal changes will be much more rapid. That's why you get colder when it rains. Um, what are the floors in their house made of? Does it need to be made of that? Could you have that conversation? And then if they've got one, we can support the skin healing. Obviously, we manage the risk of infection if the skin is broken. We are the best people to do that. Um, things which support the skin in healing. I find silicone tape, thin silicone tape works quite well. Granuflex being the sterile dressing version of it. Silicone foam dressings are good because they not only are soft and forgiving against the skin, they're also a little bit thicker, so you get a little bit of thermal insulation. Um, Tubifoam toe socks are nice because they give you a bit of cushioning and a bit of insulation, but the inside material there is quite rough, so a good trick is to line it with fleecy web, because fleecy web is lovely and soft against the skin. Got a video for how to do that. If you go onto YouTube and Google toilet CPD 12 Tubifoam, you will find the video that shows you how to make those. So there's lots that we can do there. And last and definitely not least, signposting. Because we hope that when this person gets a diagnosis, their doctor goes through all of this with them and refers them to the consultant, and the consultant goes through all of this with them, and they have it all signposted. Sadly, the NHS, wonderful thing that it is under an awful lot of stretch. So sometimes you might get a, this is what you've got, go deal. In which case we can help a great deal. Lupus UK is genuinely an amazing website.
Mm.
I hadn't been on it until I was signposted to it. And the amount of detail that they've got there, both in really easy to understand, patient-friendly language and quite technical, in-depth, practitioner-friendly language, is prodigious. It is one of the best of its type. They've also got a Facebook group, which is very, very active. Um, and getting people involved in that sort of thing, particularly social media, because social media gives you a little drip of what you watch. The more you look at things, the more the algorithm will give you. It can help you to not feel as lonely, not feel as isolated, um, because that is going to be a real problem for people. And it's purple. All their branding stuff is purple, which is just objectively awesome. So directing them towards both the website and the Facebook page is a good shout. Referral, there's going to be stuff that you're not going to be able to deal with. The medication side of things, the GP side of things, the consultant side of things, the biomechanics. If that's not something you're equipped to do or comfortable to do, you can refer on to that. If they develop wounds, foot wounds, then there's that. There's the vascular side of things. The vascular team, the claudication might need monitoring. The vascular checks might need to happen. There's a lot that we can do to signpost to people who need it. And just having a broad idea, nobody's going to remember that list of symptoms. It's a long flipping list. But if you are aware that it is a long and heterogeneous list, and a patient says to you, when you ask them how things been, oh, I've been suffering with Blair. You can go have bring up the list of symptoms on Lupus UK. You run down the list and say, oh, Blair can be a symptom of lupus. So maybe you need to go and have a chat with your consultant because they might not realize that all of the symptoms that they have. Um, so that can be really useful as well. Good communication as well. Because even if there's nothing they can do about it, if a patient with lupus comes in with, let's say, Raynaulds, and they hadn't had it before, you can bang off a letter to the GP. So, saw Miss Blogs today. As you know, you've been managing her for lupus for some while. She presented with Raynaud's, which may be connected to her lupus. Just wanted to keep you in the loop. Patients love that because they love it when their different team members talk. Doctors love it, and it's great for us because it shows the doctors that we are monitoring. these things. So, just in summary, um, the only slide that most people remember any of. Um, Lupus is an inflammatory condition where your body's immune system targets the wrong tissues, starts attacking you. It can't be cured, but it can be managed quite effectively. There are lots and lots of different symptoms, and no two people will have the same symptoms. So the usual patient over the fence diagnosis system where I've got what my neighbor has really doesn't work with this. And you might have two consecutive patients with lupus who have completely different symptom sets, completely different experiences. Be aware that that is normal. That is common. The majority of people with lupus have foot problems, mostly pain and vascular. And those are things that we need to be aware of. We need to be aware of how they are connected with lupus, and we need to be aware of how to best help them. And we can indeed